Hello everyone and welcome back to my channel, another video on clinical pharmacy practice. I'm Joe, a clinical pharmacist with over 25 years of experience, and on this channel I teach clinical pharmacy. So if you're interested in learning clinical pharmacy and practicing with me, make sure to subscribe to the channel and activate the bell so that you get notified of future videos. Now today we have a new case. It's a sepsis case, a very interesting case actually. If you're interested in intensive care and learning more about how to manage intensive care cases, so this case will be about sepsis antibiotic timing, and we should all learn something new by the end of this presentation. So for those of you who don't know, sepsis is actually a life-threatening medical emergency, and I know that people don't say that much on the internet, but it is a life-threatening medical emergency that requires immediate action. Now, the first hour after sepsis is suspected is actually very critical, and quick diagnosis and treatment, I should say proper treatment, can make the difference between life and death. Um, this presentation will focus on the essential pharmacologic interventions, pharmacotherapy interventions that frontline clinicians usually use to prevent sepsis from progressing to a septic shock and save patients' lives. And the difference between sepsis and septic shock, I teach that also on my course. Um, Sepsis is basically suspected or confirmed infection plus an organ damage, some sort of organ damage. It could be liver failure, kidney failure, whatever, encephalopathy, any kind of organ damage. And there has to be a suspected or a confirmed infection in that patient. While septic shock is a subset of sepsis where the patient enters into a state of profound circulatory and metabolic abnormalities that can actually increase the mortality rate in those patients. Um, Usually we look at patients that continue to be hypotensive despite adequate fluid resuscitation and vasopressors with a mean arterial pressure that continues to be below 65. The dramatic image of those patients, like you need to actually see those patients when they come in, how they present, and how immediately we take them into the emergency department and inject antibiotics and fluids, a massive amount of fluids, and send them immediately to the ICU. Within 3 hours, everything would be done actually, and they would be in the ICU receiving proper treatment. So hopefully you at some point you'll get to sign up for my course on my website and learn more about sepsis and how they present and how to treat them. But for today, we're going to focus on antibiotic timing and specifically the first hour of admission. Well, let's get started with today's presentation. Our patient today presents with classic signs of sepsis, basically altered mental status, severe and fever, and low blood pressure. The critical lab values indicate a severe infection, and likely when they diagnosed the patient, it was likely urinary source. And this is something that we have to identify. Where did the patient get the sepsis from? And for this patient, it was likely a urinary source, and there was obvious organ dysfunction, evidence evidenced by the elevated lactate and creatinine. So the kidneys are failing, and also there's altered mental status. So two different organs are in critical status. The delay is in starting antibiotics is concerning, as it is statistically or it has been statistically proven to increase mortality by about 7% per hour. So we need to act really quickly to optimize the sepsis bundle and give the patient the best chance of survival. Um, Time is of the essence here. The next 60 minutes after the presentation will be very critical in determining the patient's outcome. So we must rapidly administer antibiotics, fluids, and other supportive care to reverse the septic shock. I hope you got the idea from this. So what is our role as clinical pharmacists in this patient? So the clinical pharmacist actually plays a critical role as part of the code team when the sepsis patient arrives. The checklist in front of you identifies or ensures the pharmacist or the clinical pharmacist does not miss any key step during the first critical hour. And as a clinical pharmacist practicing in ICU, you should know these steps by heart. So first, we need to obtain blood cultures immediately before starting antibiotics because you want to see what kind of bug is growing. You don't want to delay blood cultures until you inject the antibiotic, and maybe you injected a loading dose of antibiotics that will kill a certain bug that we want to identify. So immediately get the blood cultures first before, or make sure the nurse gets the blood culture drawn before she injects the antibiotic. And this is a rookie mistake that happens at hospitals because the doctors when they see the septic patient, they would put too many orders. They put orders for antibiotics, orders for fluids, order for cultures. They'll put everything at the same time. So it's easy for the nurse to look, oh, I have the antibiotic here. Let's inject it now because to avoid any delay. But that's wrong because she needs to know that, or he needs to know that they need to draw the blood culture first before injecting the antibiotic. Next, we need to identify the suspected source of infection. We need to look at sources, different sources. Where could the patient have had the infection from? As this will guide us, of course, through empiric antibiotic selection. We then need to choose appropriate broad-spectrum bactericidal antibiotic, considering local resistance patterns, allergies that the patient may have, and recent antibiotic exposure. We're not going to give a patient an antibiotic that they received recently, for instance, and if they received antibiotics recently, we might want to cover for multi-drug resistant bugs. So it's important to use loading doses as well when we first give antibiotics or for the first doses of antibiotics to ensure adequate levels in the setting of shock, especially if the patient enters a status of septic shock. So if the choice was, for instance, to give a beta-lactam plus vancomycin, vancomycin has to be given in a loading dose, and some beta-lactams also can be given in a loading dose for the first dose. The goal is to have the antibiotics infusing within 60 minutes of presentation or of recognition of sepsis. And we need to communicate the urgency to nursing and consider some sort of a stat delivery right now. It has to be delivered to the nurse, or the nurse has to prepare it right now if they do that on the ward. Finally, we must document the exact time of antibiotic administration, as this will guide us in our assessment at the 48 to 72 hours later on. When we look at empiric antibiotics, the selection in sepsis requires balancing broad spectrum coverage against the likely pathogens, um, while at the same time considering patient-specific factors. The suspected source of infection is the primary guide for empiric antibiotic choice. So, for instance, if it's a community-acquired pneumonia, I would go with ceftriaxone plus azithromycin and add vancomycin, or maybe switch ceftriaxone to cefepime or piperacillin tazobactam if we are worried about pseudomonas. add vancomycin if we are worried about MRSA, and so on. If it's a urinary tract infection, third generation cephalosporins work very well, especially ceftriaxone, maybe cefepime, and we can consider a carbapenem instead of these if we are worried about ESBL risk in those patients. Also, fluoroquinolones might be an option for ESBL. If it's an intra-abdominal source, the first line would be something like piperacillin tazobactam with its anaerobic coverage, or maybe ciprofloxacin with metronidazole, again adding broad spectrum antibiotic to another one with anaerobic coverage, or maybe a carbapenem if the patient is penicillin allergic or has a contraindication to ciprofloxacin. So if what happens if we don't know the source, or we looked everywhere but we're not sure where the source is? For those patients, don't mess up. Just go with a broad spectrum antibiotic such as piperacillin tazobactam plus vancomycin to cover for MRSA. They are too risky to start with a lower spectrum antibiotics. So just go with piperacillin tazobactam. It will cover Pseudomonas, it will cover anaerobic bacteria, and vancomycin will cover the MRSA or and most gram positives as well. So septic shock causes profound, like I mentioned before, profound physiological changes that alter how antibiotics are distributed in the body. Increased capillary permeability and fluid resuscitation will expand the volume of distribution for hydrophilic antibiotics. This will result in a subtherapeutic antibiotic concentration at the site of infection, of course. And that happens in the first 24 to 48 hours, which are very critical. And this is why loading doses are essential to achieve effective antibiotic levels early enough for source control. Now, the recommended loading doses, I would say, if you're using piperacillin tazobactam, we'll give the first loading dose as 4.5 grams, regardless of what the kidney function is. Even if the patient has kidney failure, it doesn't matter. Start with a good loading dose and then adjust the maintenance doses later on. For drugs such as cefepime, for example, the loading dose would be 2 grams, meropenem also 2 grams. And for vancomycin, we usually do anywhere between 25 and 30 milligram per kilo of actual body weight. Again, even though vancomycin is a nephrotoxic drug, you don't mess up with the loading dose. You just give the full loading dose, but don't exceed 3 grams when you're calculating that, because some obese patients might actually, when you do the calculation, might actually need more than 3 grams per loading dose. Do not exceed 3 grams per dose, and then adjust the next doses, the maintenance doses, based on levels and your pharmacokinetic and pharmacodynamic calculations, which I teach on my course. We're not going to go through that now, but if you want to learn more about how to dose vancomycin using the pharmacokinetics and pharmacodynamics and the area under the curve to MIC, please sign up to the full course on our website. Fluoroquinolones are other antibiotics that have a loading dose. So for levofloxacin, it's 750 milligrams IV. And when I say loading dose, another difference between the loading dose and the maintenance doses is that the loading dose is given on a short period of time, usually 30 minutes to 1 hour max. And in case of vancomycin, of course, it depends on how much we're giving. But for the other drugs, we give it really quickly over a very short period of time, as opposed to the maintenance doses, which can be given over a longer period of time to maintain the drug concentration over MIC. Again, I teach all of that on my course. It's not our teaching for the day, but I just wanted to mention that. All right, next slide, please. Okay, thank you. Now, septic shock often leads to acute kidney injury, creating a dosing challenge. So you need to keep an eye on the patient as they progress in the ICU. Um, Sometimes we need to give aggressive initial doses to achieve therapeutic levels quickly, like I mentioned with the loading doses, but you must avoid accumulation and toxicity with the maintenance doses. So approach is a different between loading doses and maintenance doses. For the first dose, just give the full loading dose, like I mentioned, even like regardless of the kidney function. The goal here is to achieve therapeutic concentration really quickly. If um, if the patient is an AKI, that does not affect the volume of distribution of the initial dose anyway. And an example for that is a patient with, let's say, creatinine clearance of 25 mils per minute, um, and we want to give them a loading dose of vancomycin. So creatinine clearance of 25 is really low. It's not normal. But when vancomycin is a nephrotoxic, so you would worry, oh, the patient is already in renal failure. I should not give them the full loading dose then. That's not correct. You still give 25 to 30 milligram per kilo of vancomycin regardless of the initial or baseline kidney function. But for maintenance doses, you need to adjust the dose based on kidney function. There's one more thing that we do in ICU, which is the extended dosing interval for those drugs that are renally cleared. And an example of that is cefepime. When we give it every 8 hours, or every 12 hours, or every 24 hours, depending on the creatinine clearance, you inject the drug over a longer period of time rather than over a shorter period of time. But the most important thing is to reassess dosing daily um, as you oversee the patient, or as long as you are seeing that patient. If you, let's say, if you are off work the next day, you have to give some sort of feedback or recommendations for the next pharmacist to keep an eye on kidney function and redose the patient. And many of those patients, by the way, can enter a state of complete kidney failure or end-stage renal disease and require dialysis. And depending on what mode of dialysis, you would be adjusting the dose again and again, especially if it's CRRT, you have to increase the dose. If it's intermittent hemodialysis, you dose the medication differently, and so on. So the key here is to keep an eye on your patient as you go. Don't just give one dose and expect it to continue with the patient for as long as they are at the hospital. Now, the 48 to 72-hour reassessment is very, very crucial in those patients or in the ICU. Empiric antibiotics are just a bridge. They're not the destination. Think about it that way. So that's why we have antimicrobial stewardship at the hospitals. And this means we may narrow or even expand therapy later on when we get the cultural results. This critical reassessment window at 48 to 72 hours after the antibiotic initiation is what most clinicians can actually overlook, but you being there as a clinical pharmacist can easily bring it back on the table and remind everyone about it. And of course, you should be reviewing the cultures after 48 to 72 hours or whenever they come back with results. So we would be looking at cultures and sensitivities. We can now either de-escalate to a narrower spectrum antibiotic, or maybe escalate to a broader spectrum regimen. If the cultures are completely negative and the patient has improved, we can simply consider stopping antibiotics if all the markers are normal and it has proven to be not really an infectious source that caused well, the presentation of the patient. Most sepsis, however, will require 7 to 14 days of antibiotic therapy, especially if the patient ended up in the ICU. Now, complicated infections such as endocarditis or osteomyelitis, they require longer durations. You might end up with 6 weeks of antibiotics in osteomyelitis. So I'm not really talking about these now, but for other cases of sepsis, they usually require 7 to 14 days of antibiotic therapy after getting a negative blood culture. Um, and of course, when appropriate, for some cases of sepsis, we can step down to oral therapy, but not for all cases. However, that hasn't yet been proven to be 100% effective and reduces mortality and morbidity in those patients. But there is some data, recent data on that in certain staph aureus infections that we can step down to oral antibiotic safely and was non-inferior to the IV antibiotic therapy. Um, Now, if we chose cefepime as the initial empiric antibiotic choice, or in this case, the patient received cefepime as the initial antibiotic choice for that possible urinary tract source of infection, um, the culture came back with E. coli as the causative pathogen, and E. coli is usually pan-sensitive to all antibiotics, but sometimes some of them can develop resistance and become an ESBL or extended spectrum beta lactamase. But for this case, it came back pan-sensitive, so that tells me that it's sensitive to most antibiotic classes. Then in this case, we can de-escalate to either maybe ceftriaxone once daily if we still need IV therapy, or maybe oral ciprofloxacin 500 milligrams every 12 hours and get rid of the IV line in that patient. If the patient is stable enough, of course, and able to take oral therapy, like I keep saying in multiple lectures, you need to assess the patient, and if if they are a suitable candidate for switching from IV to oral. The duration of therapy here would be as if we're treating a complicated UTI with bacteremia. So 7 to 10 days should be enough duration of treatment. Um, However, if the patient's source was, let's say, pneumonia in this case, and we included vancomycin plus cefepime plus azithromycin for initial empiric therapy, the culture then came back showing Streptococcus pneumonia, which is penicillin sensitive or methicillin sensitive, MSSA. Then in that case, we can de-escalate to ceftriaxone and azithromycin alone for 5 to 7 days. And then when the patient is suitable for oral therapy, we switch to oral therapy. So de-escalation is actually a key antimicrobial stewardship principle. It reduces the risk of C. difficile, preserves the microbiome, and combats resistance without compromising patient outcome. So it's a very, very important antimicrobial stewardship principle. Now, things to avoid in such patients is waiting too long to draw blood cultures. That can be actually deadly. Don't delay that. Get cultures immediately, even if antibiotics have already been started. I know that I said before that you have to get the cultures before, but let's say the nurse unfortunately she or he went in and injected the antibiotic. Don't worry about it, just get culture still. We need that because it will help us somehow. It will help us in the future. Use the maximum recommended doses for beta lactams and beta lactam antibiotics if it's a septic shock or a sepsis, as for those patients the pharmacokinetics would be altered. Always cover anaerobes if you can. If you think that the patient needs anaerobic coverage, especially in intra-abdominal infections, add metronidazole or use a carbapenem or something with beta-lactamase inhibitor. All of these antibiotics will cover the anaerobic bacteria. And of course, at 48 to 72 hours, set a reminder to reassess every septic patient and de-escalate antibiotics or escalate them if necessary. The key takeaways in this case are sepsis, of course, is a medical emergency. Every minute counts. The key is to act quickly with right antibiotics. Start antibiotics within 1 hour of recognizing sepsis. This is very important. This can improve survival by about 7% per hour. and use high aggressive doses of antibiotics initially to overcome the expanded volume of distribution in septic shock. Always choose antibiotics that cover the most likely pathogens based on the suspected source of infection. And after 48 to 72 hours, narrow the antibiotic spectrum if you can, based on culture results and clinical response. This is a good antimicrobial stewardship. And as clinical pharmacists, we are essential members of the core team. Our interventions in the first hour can be life-saving. Thank you very much for checking in and watching the presentation for today. As a reminder, we have a complete clinical pharmacy course on our website if you're interested in practicing clinical pharmacy in the future, upgrading your career, um, um, just curious about what clinical pharmacy is. Take a look at our website www.clinicalpharmacycourses.com and sign up for the course. It's one of the best in the market right now. Take the chance as it's available. And once again, if you're not on the channel yet, make sure to subscribe to the channel and activate the bell so that you get notified of our future videos. And thanks again for being here. I'll see you in the next video.